Let's begin with a roll call, starting with Ms. Stratton.
Karen Stratton, City of Spokane.
Bob Lutz, Health Officer.
Tony Smith, Spokane Regional Health District.
Chuck Hafner, appointed citizen.
Kevin Freeman, City of Millwood.
Mike Munch, City of Spokane Valley.
Michelle Fossum, Legal Counsel.
And Fitz Stumble, Recording Secretary.
So let it be noted for the record that at this time we do not have a quorum of the board. At this time, we will move to citizen input. We have 4 names on our list today. We have, beginning with Jacqueline Gallion. Please remember that we have, limit your comments to 3 minutes, if you don't mind.
I don't mind. Hello, Jacqueline Gallion. I am a resident of Spokane Valley. I have been in contact and attended the recent State Board of Health meeting here in Spokane in June, and I have learned many things. The handling of the mumps outbreak in Spokane was a fiasco. Sketchy reports to know if any exclusion is needed for school children or working. The report must show the vaccination status by age group. There are no vaccination status unknown in the school category because you can't go to school without a vaccination status. You are either vaccinated or exempt. Also, there is no reason to mix in state numbers in the Spokane report. What was that about? With an accurate report, the policy could have been addressed right in the beginning when it was apparent all cases were in vaccinated students. This outbreak was started, spread, and sustained by the Marshallese community. Spokane Regional Health District knew this in December when they received a Dear Colleague letter informing them of this. We were told by the county health officer that there was some unidentified extremely vulnerable students at school and that the risk our exempt kids would somehow have close enough contact with a mumps-infected student that they would get it, and then be close enough, long enough to a vulnerable kid to put them at risk. Mike is throwing me off. If this is true, then why, to our knowledge, did the Spokane Regional Health District do nothing beyond offering the Marshallese a 3rd dose of vaccine when the first 2 doses didn't work? That could have been excluded family members or infected students regardless of vaccination status. As the vaccines doesn't work for them, temporarily restricting large social gatherings, etc., if there are any vulnerable students, Spokane Regional Health did little to protect them. Excluded parents were at every board meeting since January, yet we have never been given status and allowed to present our information in a comprehensive way. Even at the special meeting, we were only observers with limited interaction allowed. When the state board received information we have been trying to give to you, and it caused an immediate reevaluation of policies statewide. If we had been listened to properly, Spokane could have been on the leading edge of proper handling of exclusion instead of botching it terribly. The final result is that dozens of students have catastrophic interruptions of their education for no good reason, and were being ostracized and bullied for being different even after they were permitted back in school. It is our sincere hope that the board will impress upon the Spokane Regional District staff the importance of transparency in their reports and to respond more appropriately to citizen concerns. I also want to add that this being here for so many months and coming to every meeting, it's a very biased, one-sided avenue. It does not look at different avenues and different options of health. And it's very disappointing when you guys are supposed to be representing the people. So thank you.
Thank you. Next we have Dina Tucker.
My name is Dina Tucker, and I live in Spokane Valley. According to my constitutional rights, I am supposed to have the right to make medical decisions for my family. According to the laws of Washington, Washington has a legal obligation to educate my child. When this education is held hostage by the health district and the school districts because my decision to medically make medical decisions for my child does not fall in line with the accepted agenda of vaccination, there is a huge problem that is created. I have constitutional rights that I expect to be upheld by the people who represent the people. If this issue is truly about a health epidemic concern and not an agenda, why is it that a person can return to school after receiving a vaccination when there's no proof of immunity? Why is it that people who have vaccinations but can't prove that they have immunity are allowed to be at school if it's truly about a health concern? My recommendation is that everybody, if there's truly a epidemic, which is what the exclusion order is designed for, is happening, that everybody, so it's non-discriminatory, everybody is required to take a titer test to show if their body is acceptable for being at school during an epidemic. I think the finger pointing between the health district and the school district and the lack of accepting accountability for the actions and the powers that are abused is extremely shameful. I would hope that we could do better for our community and for our children, and we expect better to happen in the future. Thank you.
Thank you. Next we have Jennifer Powers. Burrows.
Jennifer Burrows, City of Spokane. So I recently took the time to read the Merck MMR vaccine insert, and I came across some areas of concern that I wanted to share today in light of the current vaccination policies. Aside from the contraindications of hypersensitivity to any of the components of the vaccines, individuals with a family history or congenital or hereditary immunodeficiency are also in the category of contraindication. And the interesting thing about immunodeficiency is, according to the Merck manual, 25% of people with an autoimmune disorder have immunodeficiency, but many times the symptoms are not displayed until later in life. Caution should also be employed with persons with a history of cerebral injury or a family history of seizures. Pregnancy should be avoided 3 months following vaccination because of the fact that no animal reproduction studies have been conducted. Nursing mothers should also avoid MMR due to the fact that the transmission of the rubella virus to infants via breast milk has been documented. MMR has not been evaluated for carcinogenic or mutagenic potential, nor its potential to impair fertility. Some of the adverse reactions are atypical measles, pancreatitis, diabetes, anaphylaxis, encephalitis, measles inclusion body encephalitis, which is a serious form of immunodeficiency that has a delayed onset of several months following vaccination. There have been documented cases of even a year after an MMR vaccine. On the third page of the insert, which unfortunately my printer wasn't working because I wanted to provide you all copies of, it says that there is no conclusive evidence that vaccination of individuals recently exposed to wild-type mumps or wild-type rubella will provide protection. And it is my understanding that the mumps outbreak that we had in Spokane was of the wild strain. According to the U.S. Department of Health and Human Services website, they state that despite the advantages of live attenuated vaccines, there are downsides. It is the nature of living things to change or mutate, and the organisms used in live attenuated vaccines are no different. The possibility exists that an attenuated microbe in the vaccine could revert to virulent form and cause disease. The MMR insert goes on to say, unnecessary doses of vaccine are best avoided by ensuring that written documentation of vaccination is preserved. This raises an interesting question regarding the large refugee community in Spokane. Many of them come from countries where they have most likely contracted many of the childhood illnesses we vaccinate for, but have no medical documentation. Why aren't we checking them for titers before subjecting them to the full vaccination schedule? So in conclusion, I would just like to say that there are definite risks. There is a reason that we have the National Vaccine Compensation Program and the Vaccine Adverse Event Reporting System. And so this needs to be a right that parents have to choose without their children's education being in jeopardy. Thank you.
Thank you. Next we have Rosemarie Waldron.
I'll remind any of the newcomers that I've been a regular here since 1997. So I'm sure that some of you that date back that far have the right to be somewhat irritated and bored with seeing the same face and hearing pretty much the same thing over and over again. However, I do try to update it because there's viable information to that effect. Principle among which today is I'm going to say a ditto to everything that you heard from these ladies, because I've lived long enough and survived the idiocy and the ignorance of some so-called health authorities long enough, and I've spent 50 years of my own time, energy, and money. By the way, how do you like my dress? It's made out of a recycled sheet. I had lots of fun making it. Anyway, one of the principal ingredients that is not listed, just like GMO ingredients in food, your Frankenfood now, is fluoride. And there are millions of them. It's used as a preservative as well as an adjuvant, not only in vaccines, but in chemical-based medicine, fertility clinics, and the animal and plant Frankenfood that has been in the process of being created, patented, synthesized since 1906. Monsanto was incorporated in 1901. Their first GMO was an artificial sweetener called saccharin. Anyway, I'm just going to read to you what each of you have a copy of, plus what I was able to email earlier this morning to the secretary, and she tells me that she has provided each of you with a copy of that. What I have delivered to you today is regarding the United States Environmental Protection Agency being sued to end fluoridation. Chilean research finding it's 70 years of fluoridation, just another failed public health theory. And an actress cleared her chronic acne when she stopped drinking fluoridated water. And to a previous group, some of you were seated then, I brought up the subject. That's when Mrs. Pickett was also coming, and I thank her for the information. She bulldogged that. Regarding Port Angeles, Washington, the City Council is now going to allow voters to practice dental medicine without licensure. Now, if that piques your curiosity, I hope you'll read the rest of it and go to the website. Thank you.
Thank you.
Oh, by the way, just a reminder, I'm medically and dentally double-blind control tested toxic allergic to fluorine-bearing compounds, in other words, fluorides. And I have a son who lives in Portland with the same identity, and he has 2 grandchildren who are even worse off than he is.
Next, we have the chair report, which will be brief today. I'd like to announce. Oh yes, thank you, thank you. We've had 3 members join us: Commissioner French, Commissioner Kearns, and Councilman Beggs, and so we now have a quorum for action items at this time. Thank you for attending. Chair report: Mr. Hafner has been reappointed for a 2nd term, which will expire in December 2021. At this time, Mr. French is reviewing candidates for a citizen appointee replacement for Dr. Lutz to fill the vacant appointed citizen slot. And we are looking for a new date to replace the August 9th hearing for Mr. Margitan. So at this time, as the chair, we have been just today requested a continuance for that hearing. As the chair, I'm going to grant that continuance, and we'll all be reaching out to you again to try and set another date after the district has processed Mr. Margitan's request for additional information, et cetera, et cetera. So please, I appreciate everybody's responsiveness last time for that poll, and please be aware that that will be continued, so that August 9th meeting is now sacked, and we'll be looking for a new meeting date. And that's all that Chair has at this time. So we'll move on to item number 5, the agency report.
Thank you. We'll begin with the health officer.
Mr. Chair.
Yes.
Unfortunately, I have to chair another meeting at 1:30, so I'm good here until about 1:15. So anything you need to take an action on that requires a quorum, just want you to be aware of that.
Okay. So what we'll probably do is, what are you thinking for the agency report? How long?
Probably a total of between 15 and 20 minutes.
So at this time, if I have no objections, I'd like to move item 7 up, the action items, consideration of resolution 1707, up to now, and we will delay the agency report until after then. Do you have a motion on that?
So,
Yes.
Second?
Second.
Any discussion? Seeing none, all in favor?
Aye.
Thank you. So we have Resolution 1707, adopting the 2018 Health District fee schedule by Mike.
Hi, thank you. Yes, this is Resolution 17-07. As you know, this time of year, one of the first steps in our budget process for the 2018 year is to look at our current fees and how we're going to change those up and move them around. So all the divisions and the program managers went over all their fees that we collect and submitted a proposed either fee change up, some went down, and we presented those to our executive leadership team. The executive leadership team went through the fees in quite detail and then passed those on to the Budget and Finance Committee. So I went over the Budget and Finance Committee on the fees changes. And from there, they recommended that we took it to the exec committee of the board, which we did last week. And after we went through the fees at that thing, I'm here today asking for the resolution 1707 to be passed so we can start on the 2018 budget.
Mr. French.
So if we pass this resolution today and you need to come back in November and amend these, do you have the ability to do that?
We could at the December meeting. There is no meeting in November. There is a meeting in December that we could come back and make a change to. There is minor changes that go on during the year. According to our fee policy, the director of the agency can make minor changes as the year goes along. So even if these were submitted to be a January 1st budget and something major had to be changed at that time, it could either come back here to the December 6th meeting or the director could make a minor change.
My reason for raising the issue is that it's probably common knowledge that the county has reached a point to where we're having some challenges in terms of balancing the budget for 18, and we do have a levied lid lift proposed on the ballot that would maintain a balanced budget for us in 18. If that does not pass, then we're going to be looking at cuts to be able to get our budget into balance. And currently we contribute $2.4 million to this agency, and I do not believe that we'd be able to meet that full commitment if the ballot measure does not pass. So I just want to make sure that you are aware that that is at risk, and so keep in mind that you might have to make some adjustments in December.
Correct. Thank you very much for that. One thing we do try to do, because according to the policy, all the fee-based programs are trying to stay 100% funded by their fees, and so they all could possibly fall a little short of that by staying just a hair under there. But on these ones, we really do try to anticipate what the expenses are going to be in there and set the fee at that.
Okay.
Based on Commissioner French's comments, does anybody from the board have any informational questions for Mike? Seeing none, do I have a motion at this time on Resolution 1707?
I make a motion to that effect.
Second.
Moved and seconded. Discussion from the board? Seeing none, all in favor of Resolution 1707 as presented?
Aye. Aye.
Any opposed? Seeing none. Any abstentions? The motion is passed unanimously.
All right, thank you.
Thank you.
Just wanted to mention, do you want to hit the consent agenda too?
Yeah. So, okay. So that's actually our council has made a good point. We should probably take the consent agenda at the same time, and since we've moved the agency report down below, I don't think we need another motion on that. So at this time, the consent agenda is consisting of the meeting minutes from the June 2017 meeting and the June vouchers. Do I have a motion on the consent agenda?
Move approval.
Second.
Moved and seconded. Any discussion on the consent agenda? Seeing none, all in favor?
Aye.
Any opposed? Consent agenda is passed as presented. Thank you. So now we are at the agency report, which begins with our health officer, Dr. Letts.
Well, good afternoon. In preparation for this conversation today, I sort of queried the different divisions, and I asked them, what should I be talking about? And what I heard pretty consistently was that it's a normal summer. And so I further asked, well, what does a normal summer mean? And so what I'm going to present to you is essentially what has been going on at the agency for the last couple of months. And I think it's interesting because, again, we've talked about the scope of the work that the agency does. Tony and I had a chance to attend the NACHO meeting a couple of weeks ago. And one of the take-home points that we had was that oftentimes when you think of safety, the first or second thought that comes to mind are police and fire. But another reality is that public health is also one of those safety organizations that is oftentimes behind the scenes, really very invisible. And when people start to realize all the work that is getting done here that affects the community, maybe invisibility is not the best way that we should be presenting the good work that we do. So for example, looking at EPH, the environmental public health area, there were 170 pool inspections. There were 148 animal bites inspected. There were 5 K-12 school projects. There were 80 calls and consultations for the Living Environment Program. The liquid waste program had close to 130 inspections. Solid waste program had 130 complaints that they looked at. Land development review, 35 different land actions. There were 52 new well inspections. Food safety saw 260 food areas inspected. There were 24 complaints that were further inspected, and that's just in one division. Health promotions, the WIC allocation area for vouchers for farmers markets, 2,690 vouchers at $20 a piece. Caseload for the month of June, 9,871. The breast, cervical, colon cancer and health program, serving 34 clients. There were 182 attendees at a health education event, 200 fruit and vegetable incentive vouchers given out. There were 23 community health workers currently undergoing training. 103 of these workers attended a mini conference. Communicable disease, environmental issues, EPI. Okay, so that's what we've been talking a lot about. Well, they've had 30 different types of infections that they've been evaluating over the last month alone. HIV/AIDS, 346 clients. OTP program, 960 clients. And I finish with CFS. Right now, the Infant Toddler Network is serving 765 children. And we'll be hearing later on about the Nurse Family Partnership Program. There may be some documentation that you'll see soon. There was a great article in the New York Times that has been printed up that talks about the success of this program. So again, this is all the work that the agency is doing behind the scenes, not only enhancing the safety of our community, but also really promoting health. And so for me to learn what a normal summer is at Spokane Regional Health District, this is a normal summer. Now, the second point I'd like to talk about is last month I mentioned that over the next couple of months what I want to look at is what has been identified as the 20 the 20th century health achievements, of which we say that of the 30 years of life expectancy that occurred, of increased life expectancy, about 25 years of that were related specifically to public health interventions. I just want to focus on this one today. So this graph depicts, if you will, the number of miles driven in, I think it's in tens of billions, and that's in the blue line, going up, versus the number of deaths experienced per billion miles driven. So obviously, inverse, pretty strong inverse relationship. I would argue that much of this relationship is secondary to policy. The policies that have been enacted over the years that have made our roads safer, that have made our vehicles safer, and have made a relatively accepted function that we all take for granted a relatively safe function. So just a couple things, again, going back to some federal legislation back in 1966 and 1974. In light of the fuel concerns, we actually dropped the requirements, or I should say the speed law, or the speed limit laws. Whether or not that actually affected mortality is questionable, because there were also a lot of other things going on at the time. But irrespective, the bottom line is that dropping the speed limit at that time, there was believed to be a correlation. With respect to actual vehicles, seatbelt laws in '84, what we've seen since that time is decreased fatalities. And the institution of child safety and booster seats, again, decreased mortality in infants and children less than 5, unfortunately not necessarily seen in older age children. And then the final piece of policy I would just highlight is the fact that we've had identification of high-risk populations. Drivers, we know that young drivers are a little bit more risk-taking, and we've seen that, again, they have a higher rate of accidents. Therefore, a lot of actually all states now have graduated driver license requirements. And alcohol-impaired drivers, we're obviously all well aware of that. I think there's a question mark as to whether or not other forms of impairment might be considerations as we go forward. But for me, the take-home message here is that when you look at public health interventions and you look at the success of public health interventions, much of it falls in the domain of policy. Policy can have the greatest impact. And so going forward, again, I always want to bring back the idea that public health is one of those safety features. It's one of those behind-the-scenes, invisible areas of safety. And policy, i.e. policy coming from elected officials, policy coming from governance boards, again, can really enhance the safety and health of our community. That's it for me. Any questions?
Any questions for Dr. Lutz? Thank you, Bob.
Yeah.
Linda Graham will give an update on legislative.
So to Bob's list on automobile safety, we could also add the new distracted driving legislation at the state level.
Not bad.
So I just wanted to give you a couple updates on some things that are happening or not happening at the state and federal levels. And really note the impacts on the health district and on public health specifically in this community. So at the state level, I'm sure everybody's probably heard that the legislature adjourned from the third special session without passing a capital budget. There is agreement on the budget, but it's being held up because of issues around the Supreme Court decision, the Hearst decision, having to do with the permitting of new wells. There's been a lot of that in the news lately. The legislators are still negotiating behind the scenes. Word is that if they can reach an agreement, the governor will call a fourth special session. They'll come back and do the budget and take care of the Hearst decision. The political environment's a little bit interesting. You probably heard the governor vetoed B&O tax credits that were a part of the operating budget. That has angered quite a number of legislators. So the governor's influence right now is a little different than it was before. So that's just kind of created an interesting environment. Also, there was a legislator who passed away last fall. There will be an election later this year to do a replacement for him, and that election, depending on which way it goes, could change the balance of power in the Senate. So interesting dynamics of, is that going to help push forward reconciliation on the Hearst decision, or because they want to get it done before that happens, or might that delay action until after that election. So I'm kind of watching those things to see what happens. As for impacts on our programs here, the capital budget includes funding for the coordinated prevention grants. This is part of the Model Toxic Control Act. These support environmental public health doing some site hazard assessments. These involve like the dumping, storage, and disposal of solid waste. Really, the whole goal is to limit public exposures to harmful waste and chemicals, and also protect the ground and surface waters, particularly the Spokane River. That funding is about $70,000 a year, which is a little over a third of the program's funding. And for now, EPH is dealing with the lack of funding coming in by limiting their work to really some priority complaint calls that they're getting, where they're really seeing that there could be a very direct and substantial public health impact. To give you an idea of the scale of the impact, they investigated and addressed 196 solid waste complaints in 2016. So. As for the Hearst decision, EPH also has a role when it comes to the permitting of wells. And so with all this upheaval and uncertainty out there, they're really fielding a whole lot of phone calls from the public trying to get some answers on what they can and can't do. So it's really just up to the staff workload for them. I do want to acknowledge that the county is actually being hit harder by both of these issues than we are. For example, they receive about 80% of that coordinated prevention grant funding. We get the other 20%. So they are really having to deal with the impact of not having the capital budget. So moving on to the federal level, just wanted to talk a little bit about some impacts of the work around repealing, replacing of the Affordable Care Act. One issue there is the Prevention and Public Health Fund. This provides funding mostly through the CDC that then flows down through 2 local public health jurisdictions to do a number of evidence-based programs really around prevention activities such as chronic disease prevention, senior falls prevention, immunizations, and much more. The fund has it's been lately about $930 million a year. Washington has received about $47 million through the fund since 2010. And we have received a little over $1 million since the fund's inception. So we're really concerned about that. Proposals right now call for eliminating the fund. So I've been watching that one. Also heard lots of discussion around Medicaid, whether the changes to the program as a whole, rolling back of the expansions that occurred under the Affordable Care Act. According to a recent statement I included up here, this is from the governor's office, some of the impacts in Washington state, almost 1 million Washingtonians losing their health coverage, doubling up the number of uninsured children, services being cut to long-term care and disabled individuals, and then the state's going to have to pick up another about $4 billion a year. And given our current funding climate, that would be quite a task. I just want to, actually, let's back up. Can we go back one? Whoops. Okay, there we go. I just want to give you a couple examples of direct impacts about the Medicaid here in the Health District. Our opioid treatment program. With the Medicaid expansion under the Affordable Care Act, several hundred people were able to receive treatment through that program. So a lot of concern that if Medicaid is either changed or reduced, some of those clients may no longer be eligible, or some of their coverage is going to be cut. And really the concern, that's going to leave them out without this treatment that has really helped them to become a lot more stable, oftentimes get back to jobs and get back to a much more normal life. So if that coverage goes away, we're a lot of concern of what's going to happen to those clients. Also in our HIV/AIDS program, again with the expansion, additional clients could come in. Prior to the expansion, only about 25% of our clients were Medicaid eligible, but with the expansion, that number just about tripled. And what it means for us to be able to get reimbursed under Medicaid is it frees up other dollars through other funding streams to then actually serve more clients through the program. And then finally, 2 other issues at the federal level that we're really keeping an eye on and doing a lot of work about. MCV, that's how we pronounce that acronym, believe it or not. That stands for the Maternal, Infant, Early Childhood, and Home Visiting Program. This supports 4 of our public health nurses in the Nurse Family Partnership Program, and they're able to serve about 100 families because of that funding. And the MCV appropriation is set to expire at the end of September. And so we're really working hard to get a new appropriation and really hoping we can get that appropriation for 5 years. The original one was 5 years. We were able to get it renewed for 1 year, and then the next time it was 2 years, so we're hoping we can boost it back up to 5 years. Just puts a lot more stability for the program, and I don't know, Sue may talk a little bit about what they face through that. And the program McPhee funding typically has pretty good bipartisan support at the federal level, so we are pretty hopeful, but we do have concern that it may just get lost in the shuffle of a lot of the other things that are going on right now. Another issue we're really pushing is WIC funding. As Bob mentioned, there's a caseload of about 9,800 individuals at this point. There is legislation in the works in both the House and Senate as part of the agricultural appropriations. Several changes we're hoping to see along with the funding is additional funding to breastfeeding, peer counseling, increased funding for that farmers market nutrition program, and then also we want to extend eligibility for children from age 5 to age 6. This is in order to prevent gaps for those children who don't enter school until they're a year older. So that's all of my updates there. Are there any questions at state or federal level?
Any questions for Linda? Thank you, Linda.
Thank you.
Well, good afternoon. Mike has already taken care of the piece that we had with the fee schedule and really had just asked that I identify two things for your awareness. First, the Department of Health will be here early August to audit our consolidated contract, as referred to as the CON-CON. This is just the Department of Health looking at the agreement that they have with us, and they will be doing that audit. The state audit, which has been completed, we have yet to get an exit conference date. We are expecting to hear on that soon. The good news is that we have been informed that there are no serious issues, no exit letters, no findings, and so all of that sits very well with us. I think that Mike has done a phenomenal job with his staff in assuring that we are following our audit rules really carefully. This is a piece that did succeed for us in the state budget. The Foundational Public Health Services, though the format, the framing for Foundational Public Health Services was not passed, funding for that framework was given to both the local health jurisdictions and to the Department of Health. And it was a total of $2 million that went directly to the Department of Health. Then there were $10 million for a biennium that went to the other 35 local health jurisdictions. So it has been dialogued between WASOLFO and the Department of Health that for any of the smaller counties, or any county to have any value out of these dollars, they need to have sufficient resources to at least have a half-time FTE, which is estimated to be at $40,000. Well, if you take 35 health jurisdictions over 2 years at $40,000, that's $2.8 million. So that comes off the 10, and it leaves us with $7.2 million. The Secretary of Health has decided to spend $700,000 per year for cross-jurisdictional sharing, finding ways to be more efficient in the system's delivery of public health services. So that becomes $1.4 million over the 2 years, which leaves us then with 5.8 to divide for the 2 years. That leaves us then $2.9 million per year to spread, and that will be done on a population basis. Spokane has approximately 6% of the state population. So out of the $10 million that was allocated, we stand to gain $40,000 that everybody gets, and somewhere around $200,000 for our percentage of the population. If we are selected, as some of the counties apply for those cross-jurisdictional sharing dollars, there is the potential to tap into some portion of the $700,000. But when you see a $10 million allocation and you realize what it really becomes, when we have a $26 million budget and we're standing at looking at maybe getting $250,000 a year, it does not have a huge impact. I am very appreciative that we got something. What you need to know is that research was done independently to identify what is the shortfall for public health in this state. That comes back to be $100 million per biennium. Wasalfo went forth to the legislature and asked for $60 million. The House put $40 million into their budget. The Senate put 0. The governor put 22, and we ended up with the 10. So I am appreciative that we have gotten something, but it is significantly less than what has been identified as the need that exists in the state. And as you have just heard from the commissioner, Mr. French, that the county is struggling, and we have sort of put on notice that we may not be able to get the same amount of dollars from the county that we have gotten the last year. I will be happy to show with you going forward that the county's contribution to us has been diminishing over the last few years. For many years, from 1998 up until about 4 years ago, they were working to try and stay up with the cost of inflation. They have not been able to sustain that more recently. Linda talked to you about the capital budget issue. That is just one other thing that we have to think about from the overall agency budgeting. How do we keep the ship afloat and running well in between? The federal considerations that Linda went over are huge, because it's not just the direct dollars that come to the state that help fund us, but it's the enormous amount of support that the CDC gives to states and locals that also has the potential of being diminished. So in addition to the concerns around the overall amount of dollars that we may have for next year or the following year, we certainly have concerns about the strength of the Centers for Disease Control depending upon what happens. I trust you all had a chance to see the article of our new health officer in the Spokesman from the 16th of July. If you haven't had a chance to see it, I encourage you to read it, because I think Bob shared very much the perspectives of where public health is headed and where I believe this agency has been headed for a few years. A piece that I wanted to mention is that as Bob was talking about kind of what is the normal summer and identified all those things, I think there has been some learning for him coming from the board to being the health officer to see more of the detail of what goes on and recognize there's a whole lot behind the scenes that happens that as a board member you don't often see. We invite you, as always, and I know, Mr. Hafner, you have taken us up on this in a few different programs. If you have a desire to come and see how any of our programs are working, whether it be going out with an NFP nurse, coming and seeing what's going on in oral health care, if it's any of the programs, environmental public health, please inquire. We would love to have you see and understand more about what is really happening. We, as you probably know, are an accredited agency, one of the first 11 in the United States. Our 5-year accreditation is coming up at the end of this year. Actually, the first quarter of 18 is when we have to reapply. Because we were one of the first 11, we have an extended period of time to submit our documentation for that reaccreditation. Most agencies will have 3 months. For the first 11, they are giving us an additional 3 months, so we have until June. But we are in the process of planning how to prepare for that reaccreditation effort. There is just a new House bill that has put some extra responsibilities on our public records requests. We are an agency that spends more than $100,000 a year doing public records request fulfillment. And in light of that, we now will have an additional 17 metrics that we have to track and measure. The legislature is doing this for good reason. They want to understand where are the costs being incurred and what are they for. There's also an opportunity to charge some fees now that we were not allowed to do so before, but recognize that's just another little piece that has to be documented and tracked as we go forward. I want to talk a little bit about our engagement in what is called healthcare integration. Healthcare reform is really about clinical care, but it's really about clinical care payment. It's healthcare purchasing reform. It's payment reform. Better Health Together, our accountable community of health, is working through currently phases 1 and 2 of their integration process. That stands to bring to this county about $5 million before the end of this year. Those dollars are designed to assist providers and systems in making transition. So the integration to whole person care really began with the work to integrate mental health and substance use, which we now call behavioral health. So our behavioral health organization, which is run through the county, is the merging of those two. The desire and the requirement in legislation by 2020 is that those will both be integrated into physical health, so it becomes whole person care. We are at the table, but again, this is clinically focused, and we are looking upstream of that. The piece that is very encouraging to me is that we have met, Dr. Lutz and I have just met with these folks this week. They are starting to think about upstream activity because they recognize this is what controls their costs later on. If they can prevent the illnesses that they now are burdened to pay for in the clinical system, it becomes a revenue positive move for them. So we've met with United Healthcare, Coordinated Care, and Amerigroup, all of whom are looking at issues that we don't normally think of as being of value in the clinical system. Education, housing, they're talking about equity, how do we assure that we're giving everybody equal opportunity to be healthy, and issues around social justice. So I'm encouraged, though we're not seeing dollars flow in very high quantity yet toward these upstream efforts. I believe that's in the future. As Bob mentioned, we had the opportunity to attend the NACHO conference a couple of weeks ago. The title for the conference was Bridging Clinical Medicine and Population Health. So exactly what Better Health Together is working on in this community. The general sessions, I thought, were really exceptionally good in that they presented information from multitudes of perspectives. The first general session had a health officer from Harris County, Texas, which is one of the largest health jurisdictions in the nation. It had the leadership from the American Hospital Association, a very intriguing presentation by the Kansas City Chamber of Commerce director, who said basically to an audience of a couple thousand people, you all have a language that you speak amongst yourselves, but there's hundreds of thousands of us out there who don't understand that language. And he proceeded to then talk about what they have done in Kansas City that really is impacting public health by showing the financial benefit to businesses and organizations of doing things that we're talking about being upstream. They have made a significant impact in Kansas City, and we were asked partway through the NACHO conference for not inviting him to each of our communities because everybody wanted to run up and have him come speak to us. But they're doing some amazing work, and we will be trying to replicate some of the information that he presented with the numbers that apply here. Finally, I think there were several sessions that were very divergent. So we talked public health ethics. There was a pre-session conference that Bob and I were able to go to, but there were pieces on informatics, environmental quality. You can see the braiding of funds, programs specifically, wide variety of things, and impacts on looking at how law is involved in bridging health and healthcare. So public health is evolving in a world of healthcare transformation. I believe the work that we have been doing in this community is on the leading edge of what's happening nationally, but we are clearly in the direction that everybody is moving. So I'm feeling very positive about where we are. It is absolutely terrific to have Bob on board. so that I can be talking the non-medical issues and he can introduce the pieces medicine really listens to better from a doctor. So with that, can I answer any questions?
Questions for Tony? Thank you very much.
Thank you.
So, sorry. Next on our agenda, we move to our reports. Item number 8, we have a presentation today on Nurse Family Partnership Program. Sue Schultz and Barbara Brock.
Okay, thank you very much. Let me find my PowerPoint here, and then we can go ahead. All right. My name is Susan Schultz, and I'm the program manager for the Nurse Family Partnership Program that we have here at the Health District. I also manage the other nurse home visitation program that we have, which is the Early Intervention Program, and that program provides registered nurse support for families referred to us through the CPS system. But what I'm here today to do is talk to you a little bit about the Nurse Family Partnership Program. In your packets, I did provide you a copy of a handout that we have recently put together, and of course, after you have it reviewed numerous times, you always find a typo. There is a small typo on it, and I'll clarify that for you. But this is just a single-page handout that goes over, the goals of the program, some of our outcomes, a bit of a profile as far as the demographics of the population we serve, numbers of visits that we've accomplished, and then, I think really gives us an opportunity to think about the cost benefit of programs like this. We do get a lot of support from both the state and federal governments as well as the health district, and there has been a lot of research that has demonstrated that for every dollar invested, there's a significant amount that is saved in the future for these families that participate. I also have Barb Brock with me, and she is a community member, and she has made a personal decision to support the Nurse Family Partnership Program, both financially and in the community. And she's just a wonderful community advocate for us, and I'm going to ask her to share with you a little bit about her journey to support our program. Okay, so what is the Nurse Family Partnership Program? What it is it is an evidence-based nurse home visitation program. We have had it at the Health District since 2008, and we originally had the program funded through federal and state grants, and then we also had some local health dollar that were contributed to that. And we participated in one of the very few independent nurse family partnership studies, and the data that we collected provided a lot of information about the fathers of these babies that had never been done before, and that work was done in coordination with Chris Blodgett and WSU. Our current capacity is 175. We just added our 8th nurse, and she will be starting actually next week in the program. The goal of the program is to really improve the health and well-being of these moms and their babies. We start visiting early in pregnancy, and we continue to visit on a very regular basis until that child reaches age 2. And there is really a lot to learn for these moms, and by having the support of a specially trained nurse home visitor, they're able to make significant changes in how they parent their baby, and we're seeing some amazing outcomes as a result of that. Funding for our program continues to be a bit of a challenge. I know Linda had commented about the McV funding, which is a significant funding source for our program. 100 families are supported as a result of the McV funds, and that federal grant is a little over $700,000. So you can see that we do receive a significant amount of money from the federal program. Should that not be reauthorized, it will decimate evidence-based home visiting programs throughout the nation, and I think that it would be a terrible tragedy to see that happen. Another source of revenue for this program is we're receiving some funds through the DSHS program for families that are receiving TANF, and TANF is Temporary Assistance for Needy Families. And so first-time mothers who have gone to the community service organizations and have applied for TANF can be referred to our program, and we've received funding to provide services for 25 families. Those families tend to be very high risk and require a lot of effort and energy on the part of the staff, but we're seeing some amazing outcomes as a result of that. And then we have 50 families that are supported through the health district, and the health district in our budgeting process has continued to fund this program and really advocate for it in the community, and it's exciting to see that continued support for this amazing program. This is a picture of one of our nurses, Jan Boston. Some of you may know Jan. Jan recently retired. Her last day was the 29th, but this is a family that she visited, and this little guy, it was the final visit, and he had just turned 2, and he was excelling in every single avenue, and they had a wonderful relationship. And in fact, after she graduated, this family, they asked if she could continue to see them because she was trying to get pregnant again. She wanted to have another baby. So, a beautiful relationship was established between the nurse and the family. The father participated. The child was growing and developmentally on track, and they really attributed a lot of the success of their parenting to their relationship with Jan. And I think it's just exciting to see things like that happening in our community. What we do have in Spokane County is a pretty high-risk population of clients that we're serving, and I think that is very different than many parts of the state. And so what I did include was some statistics that I think are really kind of interesting. We do have high rates of smoking in our community, and I don't think that's probably a surprise to anyone, but at intake, about 23% of our women are smoking. With support from the nurses and education and using motivational interviewing strategies, we have been able to have them decrease the amount of cigarettes that they're smoking significantly, and we're seeing improved outcomes as a result of that. Our community also has significantly higher rates of domestic violence than any of the other NFP programs in Washington State as well as the nation. At intake, 5.3% report they are involved in an intimate partner violence situation, and that number is low compared to what we believe the real truth is, because that is an intake before a relationship has been established. We also have this is a success, but we have a low rate of preterm births, and so 5.5% of our babies are born preterm, and that is significantly lower than the Spokane County rates. So just kind of some of the other additional characteristics that I think that are important are the median age of our clients that we serve is age 20. So we're not just enrolling really young first-time moms. We are our youngest client that we've served has been 13, and then the oldest mother that we've had has been 47. So we have a wide range of parents. The requirement is that they be first-time parents, and they have to be less than 28 weeks pregnant in order to enter the program. And participation is voluntary, so they need to really want to do that. So the other thing that I think is different is that the poverty mix that we have here, people look at Spokane and they don't often think of this as a high poverty community, but what we see in our community and the clients that are enrolled in our program are very high rates of poverty. The average income at intake of our families is less than $7,500 a year. So I know I couldn't survive on that, and yet many of these young families are trying to get by with that very, very small income. 90% of the families that we serve are on Medicaid, and should there be changes with the Medicaid system, many of them and their children will no longer have health insurance, which will impact health and in the future. We have a much higher utilization of TANF, Temporary Assistance to Needy Families. Almost 40% of our moms are on TANF at the time that they're enrolled in the program. And one of the things that we see is that over time they come off of that government assistance, return to school, return to work, and really become very self-sufficient. But we have, comparing that to the other NFP programs in Washington, only 20% of the clients in other NFP programs in Washington are receiving that kind of assistance and intake. And nationally, the number is only 6%. So we have a very high rate of poverty. We have really high-risk families that we're serving as a result of that. We have really great utilization of resources in our community, early access to prenatal health care, which is one of the reasons why our preterm birth rate is low, and we have lots of great resources. So when you look at, these are some of our outcomes, and I wanted to show you just a comparison. So preterm births in the NFP program, on the previous slide, I believe it was 5.8%. And in Washington State, let me see, Spokane County, the rate was 6.4%. And so we are, our babies, through the support of the moms, through this program, are being delivered healthy, and they're doing a great job. One of the other things that I think is pretty exciting is the subsequent pregnancy rate. And when I first did some research on that, I was kind of astounded, but that almost 40% of the births in Spokane County were unintended in a 2-year period. 41% of births in Spokane County occur less than 18 months from the previous birth. So that is, those babies are less than 2 years apart. And 55% of births to women on Medicaid are unintended. And you compare that with the work that is done with our nursing staff, 18%. The subsequent pregnancy rate for women in our program at 18 months is only 18%. So they're working with the nurse, they're getting education and support, they're making decisions to increase the intervals between pregnancies so that they can return to work and school and successfully parent their babies. And so we're excited to see things like that happening. Breastfeeding rates are another area that we're seeing significant improvements in. Just generally in Spokane County, 92% of women initiate breastfeeding at birth. The rate of our program is 98%, so more women are being encouraged to breastfeed their babies initially. The number that is really exciting for me is that 40 to 50% of these moms are continuing to breastfeed at 6 and 12 months. And so we're, with support, they're being successful at breastfeeding, they're feeding those babies, they're establishing a really strong bond with the family, with their children, and moving, forward. This is another factor. Our immunization rate is significantly higher for families enrolled in this program. In 2016, 100% of our 2-year-olds were fully immunized at the time of graduation. That number is higher than what our cumulative average is, but I really attribute it to the education and support that the nurses give these families. We don't tell them what to do. We use motivational interviewing strategies. We partner with them and help them to make the decision that is appropriate for their families. The other thing that, when we talk about kind of the high-risk nature of the clients that we serve, is that adverse childhood experiences, or ACEs. On average, the number of ACEs of a childbearing woman in Spokane County is 3. We did a study of our clients, and the average is 7 for the families that are enrolled in NFP. So I hope you're seeing a picture of a very high-risk population, a significant amount of mental health issues, most of it untreated, lots of unsafe relationships, a lot of violence that they're dealing with. Homelessness is a huge issue, and that has increased significantly over time. Unsafe, unstable housing, issues and concerns with infestation and other types of things. And so the staff are having to deal with these families. And most times those visits occur in the home, not always. If it is an unsafe environment or they're homeless, we've met at the park, we've met at the library, we've gone to a variety of places. But it is exciting to see. This was an article that was in the newspaper. It was in April. And the reporter followed one of our nurses out to a family. And this is Alyssa. She's one of our nurses, and she's weighing a little baby. And the mother has really contributed to her success in parenting to the support that she has received. This was a mom that really struggled with connection and attachment, and she really has formed a really significant bond with her baby. One of the things that I'm required to do for our funders is to on a quarterly basis, provide them with a success story or a story about some of the clients that we're serving. And I do have those available, and if anyone is interested in reading them, I didn't want to publish them because there may be just enough truth in some of those stories that you might even recognize who some of those individuals are. But we are seeing major changes happening in the lives of these women. It's pretty exciting to see. The other thing that is just super exciting for me is that as a result of our outcomes and the strength of our program, we have been asked by Dr. David Olds and the National Nurse Family Partnership Organization to participate in a trial research program where we're going to be doing a trial of providing this program to women who have had previous pregnancies. And I'm super excited about this because there's a whole lot of families that can benefit as a result of this trial. We've committed to participating in the program for a 3 to 4 year period. We will enroll 25 to 30 women who have had previous pregnancies that are considered high risk. And by that we mean someone who's had a preterm birth previously, who is substance use, who is potentially has mental health problems or been involved with the child abuse system. And just thinking about within our agency, really, if we can make connections with some of the providers and work with our opioid treatment program, we have many, many families that will benefit from this support that they're able to receive. And then this is just a statement from Dr. Olds, who is the founder of NFP, and I think that this is really why I get up every day and do my job, is because we are seeing changes that happen. Terrible things can be prevented. Spokane County has a way too high rate of child abuse and neglect. I think they have, was it 50 per, it's like 50 per, let me tell you what it is. It is almost 50 per 1,000 children, and over 50,000 incidents of child abuse were verified in Spokane County in the last decade. And this program has demonstrated research-based findings that show that we can provide a 48% reduction in child abuse and neglect. We can reduce the number of emergency room visits. We can, these babies can grow and be on track and be ready to attend school, and with the help of the nurse, get the support that they need to make, changes and move forward with their lives. And so you can kind of tell I'm a little passionate about it, but it is an amazing program, and I'm just really excited to see, some of the changes that are happening. There was a recent article that I think Sheila has distributed or will distribute. This was just in the New York Times, and I think this is a great article because it talks about the outcomes. It talks about about the visits. A nurse will go into a home with a 12-month child. They'll be playing on the floor. They'll pull out a doll. They'll do all sorts of interaction. But really, what they're doing is they're modeling relationship, and they're providing that unconditional support. Many of these moms don't know how to play with their babies. They've never had anybody play with them. They don't know nursery rhymes. They don't know any of those things. They don't know how to attach. And by working with a nurse, they're able to get that accomplished. I'd like to ask Barb to come up, and then I'll be willing to answer any questions that you might have. But this is Barb Rock, and she's a community member, and maybe she can tell you a little bit about her background.
Well, thank you, Sue. That's really exciting about the research with Dr. Olds coming up. My involvement, I'm just a community member. I really know nothing about this topic. But I read this book, A Path Appears, a few years ago, Nicholas Kristoff and Sherry Wudunn, and I remember going through and finding about, 12 organizations that I thought changed the world. And the top of the list was Nurse Family Partnership. And I had no idea there was one in Spokane. And I think within a couple months of me reading this, there was a real nice coverage a couple years ago in the paper. And I thought, so I met Sue, and the rest is history. But I wanted to just mention a couple things. My sort of philosophical background of it started in this building maybe 30-some years ago. I know a lot of you probably know Lynn Everson. She's been a friend of mine for that many years. And I was at a meeting of veterinarians, and Lynn was the guest speaker. I mean, go figure. She was a guest speaker in my classes 3 times a year ever since then. But we always joke about veterinarians. Why was she talking about street kids and prostitution to a group of vets? We don't know, but we know that that was the beginning of our friendship. And someone in the meeting asked Lynn, you know, it was a moving presentation. They said, what can we do? And Lynn just said one thing. She said, love your children. And I think I was pregnant with my son at the time, who's now 28, but it's like, man, you know, it's just this confusing thing. What does she mean by this? So coupled that with a quote that I've always loved by Leo Tolstoy that says, age 5 to 80 is but a step, but birth to age 5 is an appalling distance. And those two things are kind of where I'm coming from, that I recognize, like I said, I'm not an expert at all, but I recognize the importance of this young interaction with the kids and with the pregnant moms in particular. Then fast forward to today, and I'm kind of sort of recently retired, but I rock babies in the NICU on Wednesdays. Again, totally out of my comfort zone, my area, but I love what I do. Been there a couple years and become very much aware again of the importance of these moms and these babies and the drug babies and all kinds of things. I see it all, you know, every week and hear a lot about it. A couple little quotes that I just thought I'd share with you if you haven't read the book about this issue. Children's programs are most successful when they leverage the most important and difficult job in the world, parenting. Give parents the tools to nurture their child in infancy, and the result will be a more self-confident, resilient individual for decades. It's far less expensive to coach parents to support children than to maintain prisons years later. So what does that mean for all of us? If we want to nurture university graduates, maybe the most cost-effective way is to donate not to a college, but to a nursery school, a parent visitation program. We wish more donors would endow not just professorships, but also the jobs of nurses who visit at-risk parents. We wish tycoons would seek naming opportunities, not for concert halls and museum wings, but for nursery schools. So again, I'm hoping, and maybe somehow I can help this process over the next few years, but I really think people want to give, especially now. People want to give. I am certain of that, but they don't know how to give. They don't know who to give to. They don't know where their money's going. They don't know if they can trust this and that. So I'm thinking, you know, Nurse Family Partnership could have a sponsorship, you know, adopt a family, to have a Friends of NFP. Something I think could happen probably as a result of all of you getting your heads together and coming up with support. You know, my dad always said giving with warm hands is pretty cool. So I think that's what people will embrace if we give them those chances.
Good. Thank you.
Yeah.
Thank you. Thank you, Barb.
So I am open for questions if anybody has any.
Questions for Sue? Karen.
I have a quick question. Have you ever received any, or have you applied or ever received any funding from the city's Community Housing and Human Services program?
We have not. So I know that has come up in the past.
Would you like me to send you some
That would be
information
wonderful.
on that?
My information is in there, or I can also just be emailed if you're on the email list.
Okay, I
So-
will make sure that you
Okay,
get some of it.
that
There may be
that would be wonderful.
some funds in there that might be appropriate for what you're doing. And
Okay.
thank you so much for what you do. This is
thank you.
Amazing.
Thank you.
Mr. Hafner.
I have a couple questions. First of all, how do you discover the families that you want to provide this service to?
Okay, families that were referred to us, it is a strictly voluntary program. The community service organization where individuals go to apply for benefits is one of our primary sources of referrals, but we also receive referrals from OBGYN providers in the community, from the federally health-funded health centers, the Chaz Clinic and the Unify Clinics. Those they're supporting our program. We receive referrals from the schools, specifically the alternative high schools, and we've reached out to the school nurses to get the information out there. And the WIC program, our internal WIC program is our greatest source of referral. About 70% of the referrals that we receive come directly from the SRHD WIC program. And then once those referrals are received, I review them to make sure that they meet the minimum qualifications, which is basically first-time pregnant and early in pregnancy and low income. And then the nurses reach out and set up an appointment and start the process.
Okay, with a capacity, with 175?
Once we get everybody up and running, yes.
I'm sure you have more families that are requesting the service.
We do. At times we do have.
With 8 nurses,
yeah.
They are, I guess, responsible for approximately, 8 divided into 174,
yeah.
and about, what does that add up to? Quite a few families.
The highest caseload that a nurse can cover is 25 families.
25 families.
And the reason that number is as low as it is because of the frequency of the visitation and the amount of data that is collected. We have requirements with the National Service Organization to collect data to submit, so that I have reams and reams of data about outcomes that I can pull up at any moment and compare our program to other programs. And we have what are called fidelity measures, and we have to demonstrate that we're presenting the program according to the way it was designed. And that's how you get the good outcomes, by doing it the way it was designed.
Okay. With the last question, how do you know if the family is meeting all your criteria so that you can go to another family?
Well, we will continue to see them until they are age 2. So,
age 2.
Yeah.
Okay.
So, we have had young women who have entered the program who have been on TANF. They have completed their schooling. We had one individual who actually was a college student. She completed her college education. It was actually, she was in a master's program, but she met the low-income criteria, and she actually got a research program that she went to. We've had families that have bought homes. We have had, people that have been unemployed. And just really living within a culture of poverty, who have made changes in their lives and moved forward. It's exciting to see the changes.
And with your help and with nurses' help, you determine what stage 1 is, stage 2 is, with the particular family then.
Yeah, and it's very much client-driven. So it is a strength-based program. It is client-driven. The clients identify what it is that they want to work on. They establish short-term goals, which lead to longer-term goals, with really the emphasis not only on child development and parenting, but also long-term growth of the parent. We want that parent to complete the program and, have developed enough skills that they can, be self-sustaining in our culture and move out beyond the environment of poverty that they have lived in.
But your involvement ends at age 2.
Yes, at age 2. And at that time, we tend to refer our families, if they need continued support, to either Early Head Start or the Parents as Teachers program, which can serve these families a little bit later.
Other questions? Thank you very much.
Thank you so much.
So this brings us to item 9, our board member check-in. Ms. Stratton.
I don't have anything.
Mr. Biggs?
Nope.
Mr. Hafner?
Nope.
Nothing from myself and Mr. Munch.
Nothing today.
So our next meeting, we'll have the old mics back. Our next meeting, good Lord, is August 9th. I know that Ann will be, no, it's not. That's what I'm just reading what I'm supposed to read. So our next meeting is what? August?
Unknown.
September 28th. So we have no meeting in August. So September 28th, but somewhere in between there, we will be contacted regarding the March 10 appeal hearing to set a special meeting and hopefully attain a quorum to that. So at this time, do I have a motion for adjournment?
You do.
Have a second?
Second.
All in favor of adjournment?
Aye.
This meeting is adjourned.